So I'm going to talk about a little bit difficult topic. Lymphomas, as you can hear from our chairperson, you have a whole specialty just going into lymphomas and leukemias, and you also have a specialty with lymphoma pathologists. So this is a very complicated issue, and I'll try the best to move forward within this area. So I was asked just to talk about basic mechanisms of conjunctival and orbital lymphomas. I'll try to do that. I'll not go into so much clinical work. I'll not go into treatment strategies and so on. Here we are going to talk about basic mechanisms. Here you have a typical conjunctival lymphoma, and here you have a typical orbital lymphoma, and this orbital lymphoma is caused by this Epstein-Barr virus inducement of this translocation, where you can see the gene has been translocated to another place. Many of the lymphomas develop due to translocations, in fact. This is the Epstein-Barr virus, a herpes virus. And what do we know about lymphomas? So in fact, we have many lymphomas. 20 cases per 100,000 person per year in the Western world. For some reason, 90% are B-cell origin. There are very few T-cells in the conjunctiva. There have only been 10 cases described so far. This is very strange. We see that worldwide we have more than 500,000 people developing lymphoma each year. 300,000 people die of this each year. In the United States, there are more than 5 million people suffering from lymphomas. They make up like 3 to 4% of all cancers and making it the 5th to 7th most common form. And in children, it's the 3rd most common cancer. So many people are unfortunately suffering from lymphomas. So what is lymphoma? So here you can see this progenitor cells from the lymphoid, myeloid, and erythroid. And from the lymphoid, you can develop B cells, T cells, and natural killer cells. So from this, you develop lymphoma. So lymphoma is a solid neoplasm, in contrast to leukemia, which is a malignancy of circulating cells. And what is the definition of a lymphoma? It's a monoclonal proliferation of lymphocytes. And from all these different maturation cells, you can see different lymphoma types develop. So if it's very early, you can see this is a lymphocytic leukemia or lymphoblastic. And if it's much later, you'll develop follicular lymphoma or large B-cell lymphomas and so on, that I'll come back to. So the development of lymphoma, this is called lymphomagenesis. And when a B cell in the bone marrow, here we have the bone marrow, then it's having this translocation, and it's transformed from a pro-B cells to a pre-B cell. Then it leaves the bone marrow, comes out into the bloodstream, and then it's been introduced to an antigen. And then it goes into a secondary lymphoid tissue. And what happens in this lymphoid tissue, it could be the lymph node, spleen, or tonsil, and probably also in our region, it will be in the mold tissue. So you don't need to go all the way to the lymph node. This would happen in the mold tissue, mucosa-associated lymphoid tissue. Here you have, the lymphocytes undergo modification via this somatic hypermutation and class switch recombination. And this induces a lot of point mutations, deletions, insertions. And from this, you will develop follicular lymphoma, diffuse large B-cell lymphoma, or maybe Burkitt's lymphoma. Then the lymphocyte leave the secondary lymphoid tissue, either as a plasmablast or memory B cell. So in order to get it a little bit back again, so we have more than 40 different subtypes. We classify all our lymphomas into morphology, immunophenotype, genetics, clinical features, and this has something to do with treatment and the prognosis. This is the reason why we do this. So if I'm going to give you an overall picture of what is the whole nature of lymphoma, we subdivide them into low grade or high grade. So the high grade, they are very aggressive. The systemic spread is frequent. Cure is possible, but many die of disease and you have a high death rate. So I'm only going to talk about 4 different lymphoma subtypes. Extranodal marginal zone lymphomas, follicular lymphomas, they're both low grade, and then we have the high grade diffuse large B-cell lymphomas and mantle cell lymphomas. Otherwise, it's too complicated. These 4 subtypes make out the vast majority of the lymphoma subtypes. When we get a specimen, I'm also the eye pathologist besides being the clinician, we apply all this. And why do we do this? Because this has something to do with prognosis. We tell the clinician back that you have this and this subtype, and this has, again, then the clinician knows what to do and what the prognosis will be. So what do we know about ocular and axial lymphomas? They constitute only 1% of all lymphomas, 15% of the malignant tumors in the ophthalmic region, so it's the most common orbital malignant tumor. And then the ocular and axial lymphoma consists of conjunctiva, the eyelids, the lacrimal gland, lacrimal drainage system, and also the orbit. So what do we know about etiology and risk factors? We know, and there's a confirmed evidence, that with Sjogren's disease, you will develop mold and diffuse large B-cell lymphomas. With SLE, you may develop diffuse large B-cell lymphomas. Rheumatoid arthritis, similar. Celiac disease, here you will develop enteropathy-associated T-cell lymphomas. Then I'm going to talk a little about infectious agents, and I'm coming back to that. Helicobacter, chlamydia, also viruses, I'm going back to that. And then, this is interesting, high body mass index is confirmed evidence developing diffuse large B-cell lymphomas, and then also cigarette smoking. So many of the lymphomas use this pathway. It's called the nuclear factor kappa light chain enhancer of activated B cells. And it's a family of transcription factors that control the conscription. And this is, in fact, happening in many of the different lymphoma subtypes. So they're using the same pathway. So in mantle cell lymphomas, which is one of the high grade, we see the molecular diagnostic features are cyclin D1 mutations. Follicular lymphomas have a BCL2 translocation. In the diffuse large B-cell lymphomas, you have this gene expression profiling. I'll come back to that. And in the mold lymphomas, you have this MALT1 gene expression. But this is only happening like in mold lymphoma in 60%. So we don't really know what is happening in the other 40%. So we know that the marginal zone B-cell lymphomas occur from the marginal zone, and also that the follicular lymphomas arise from this area, the diffuse large B-cell lymphomas from close to the germinal center, and the mantle cell lymphomas from the mantle zone. So the ocular surface is somewhat very sophisticated and a little bit complex, but on the other way, not. We do not have lymph nodes in the ocular surface, even though it's extremely efficient. So in fact, we have this lymph node spread out on the entire ocular surface. And this works very good. And then we have this mucosa-associated lymphoid tissue. And as you know, it's very efficient due to the innate immune system that we're using on the ocular surface. This is all the chemokines and so on, where lymphocytes are not involved. And then we have the adaptive immune system. This is what the normal conjunctiva looks like. If you look at a completely normal person, you will also see, beside the goblet cells, a few scattered lymphocytes. This is the conjunctival follicle. And this is the immune system very close by the ocular surface. And all these processes I've just talked about probably happen here, whether nobody really knows for sure. This is what the follicular reaction looks like. And the follicles, as you can see it here, this is what it looks like clinically. So one big question here is, so why do we develop a lymphoma in the conjunctiva? Why was it not developed in the eyelid or in the orbit? Very little knowledge is known about this. But this could have something to do with this so-called lymphocyte homing. So here we have the lymphocyte, and it starts rolling. It's activated. Here you have these chemokines on top. Again, it starts adhesion, and then we have this diapedesis. This is somewhat looking that if you have a lymphocyte, how come that this specific lymphocyte knows exactly where it's supposed to go out of the vessel, either in the lymph node or in the mold tissue? So this has probably something to do with the surface receptors, or it has something to do with this. Do we know anything about this in the ocular surface? Not really. We know that they have these adhesion molecules and these chemokines, and they are both very important, but how this interplay is working is still very doubtful. So we have this lymphocyte, comes into the mold system, and then we have some memory cells, and for some reason it turns out and it ends in this specific organ. So in contrast, lymphoma dissemination, unlike metastatic spread to other types of cancer, is not an effect of tumor progression, but more a physiological behavior. So this is more lying in the genes of the lymphocyte. So what are the cancer causes of lymphoma? We know that the Hiroshima bombing increased the risk 10 times of leukemia. And then we have all these different virus types. We have Epstein-Barr virus causing Burkitt's lymphoma, immunoblastic lymphomas. We have herpes simplex virus causing pulmonary effusion lymphoma. And we also have this human T lymphotropic virus type 1 causing leukemia, adult T-cell leukemia lymphoma. So we know that viruses are causing these diseases. So the general idea there is an infection in the local tissue. This could be in the conjunctiva. This causes the inflammation. And due to this, you have reactive oxygen and nitrogen. You have some cell damage, and then you have the transformation, the malignant transformation, or the translocation. So we have had a long debate in mold lymphomas in the ocular region. Is this caused by Helicobacter? Is this caused by chlamydia? Is this causing the lymphoma? And of course, we looked into this. At least we know that it's activating the NF-kappa B pathway, as I just talked about. We did look into the mold lymphomas of the conjunctiva. It could be very easy if we could find Helicobacter there, because we know that Helicobacter is causing lymphomas in the gastric bowel. Unfortunately, this was not the case. This is the control of the mold lymphoma in the intestine. And this is what it looks like in the mold lymphoma of the conjunctiva, so it's completely negative. And also PCR for the Helicobacter is completely negative. So unfortunately, this has nothing to do with Helicobacter causing mold lymphoma in the ocular region. Now, since we're still puzzled about this, what is causing the lymphoma, we just finished with my PhD student, Lauke Mikkelsen, sitting in the audience, this NGS-based examination, where we looked at both DNA and RNA sequencing for orbital extranodal marginal zone lymphomas. And because we have had this theory for many, many years that we need to find this organism. But I can tell you, unfortunately, we did not find any viruses causing this, and we did not find any bacteria causing this. So it's completely negative, but at least it gives us some kind of information. So mold lymphomas may develop in various regions, being induced from only one mucosal site. So it could be induced in the intestine, causing the mold lymphoma in the conjunctiva. So what do we know about the lymphomas? Half of them are men. It's a disease of the elderly. Normally you have symptoms for 10 months and its first presentation in 80% of the cases. So it's an age-specific incidence. You can see it's a disease of the elderly. And why is this? It's probably because, as you know, DNA damage accumulation occurs with age and causing dysfunction of different mechanisms. And this is, of course, regulating the genomic integrity. So this is also the reason why we get cancers with age. We know that we found in our material that there's an increase of lymphoma cases, also worldwide. And 50% of the lymphomas are in the orbit, 25% in the conjunctiva. It's rare in the lacrimal gland. It's extremely rare in the lacrimal sac. And it's also very rare in the eyelid. And Sarah is going to cover the intraocular lymphomas. Most of the lymphoma subtypes in our region are mold lymphoma. And this is very strange because in contrast to other places, you only have like 10% of mold lymphomas, but in the eye region you have close to 60%. The other subtypes are pretty similar, distributed with diffuse large B-cell lymphomas for 15% and mantle and follicular lymphomas in 10%. So mantle cell lymphomas, they are mostly bilateral or could be bilateral, which is very rare for the other ones. I'm not going to talk about survival, but just give you this short sketch. The overall survival is around 60% for our lymphoma in total. And the reason why we want to divide it into all these subcategories again is that 20% or 28% is this 5-year overall survival for diffuse large B-cell lymphomas and mantle cell lymphomas, whereas small lymphomas and follicular lymphomas have a pretty good prognosis. I'll talk very vaguely and shortly about marginal zone B-cell lymphomas. Again, you heard about this, but these are the specific translocations we see and we know is occurring in EMZL lymphomas. So here we see the pathways. We have, and this is the most common one, API1, I2 MALT1 fusion protein. We also have these other two translocations. This is the pathway we talked about occurring. And as I said, 8% of the B-cell neoplasms are mold lymphomas outside the region, but in the eye region it's more and close to 60%. Half of the patients are women, 70%, and there's this correlation with morbus Sjogren's disease. We did do the FISH testing, and as you can see from these results, this is not causing all the mold lymphomas. For some reason, and in other studies, looking all over the rest of the body, like 25-30% show these MALT1 translocations, but this is not the case in our region for some reason. Very shortly about malignant lymphoma of the lacrimal gland, which is rare. We, in our cohort of patients, were able to retrieve close to 30 patients. And for some reason, again, you can see a high percentage of 37% having extranodal marginal zone lymphomas, and a higher percentage having follicular lymphomas than in the rest of the ocular nexal region. And we tried to look into this, say, why is it in this configuration? Is this the same distribution as you have in the other salivary glands? At least you have much less follicular lymphoma, but it's not really following the rest of the ocular region. So for some reason, you have a specific region regarding the subtype of lacrimal gland lymphomas. Lymphomas of the lacrimal sac is extremely rare. There are only like 15 cases presented worldwide. So why do we have a mucosal surface encountered so very rarely with mold or other kind of lymphomas? We do not really know about this. We just wrote up the WHO book, And as you can see from this, it's very important that you know these epiphyseal symptoms and so on in order not to overlook these cases, because these are not so nice cases and giving devastating odds for the patient. This is the distribution there, but since we have so few cases, it's difficult to say something very definite. Follicular lymphomas of the ocular and axial region. We heard about earlier that we have one translocation in the germinal center, but in order to develop a follicular lymphoma, you need another malignant transformation, and it could be either of these. This is what the follicular conjunctival lymphoma looks like, and due to this translocation, we see an overexpression of the BCL2, which is an anti-apoptotic protein, so the cells will continue dividing. We have this translocation, 14-18, and in most of the cases, and we try to look into, because there's a different histology of this, and we have grade 1, where depending on how many centroplasts you see in this, and we know that there's a difference, meaning that grade 1 and 2 have a much better prognosis than the grade 3. And we could see from this that the focally follicular or the diffuse tend to have this translocation, and it also tends to have relapses. So whether the tumor will relapse has something to do with what translocation the tumor will demonstrate. Diffuse large B-cell lymphomas. There are many different signaling, again, mostly going into the NF-kappa B pathway. And again, you can see it here. You can look at the MID88 signaling. And what is interesting is that most of our lymphomas and diffuse large B-cell lymphomas are localized in the orbit. And it has very much to do with what subtype, whether you see centroplastic or immunoblastic subtyping. With mantle cell lymphomas, mantle cell lymphomas has something to do with the chromosomal translocation, 11-14, giving an overexpression of the cyclin D1. And the cyclin D1 is very important in the cell cycle. And here we see the cell cycle, and you can see the retinoblastoma gene here, which is activated. For some reason, the mantle cell lymphomas develop a lot of bone marrow involvement. We do not know exactly why some of these lymphoma cells tend to localize in the bone marrow, but this is very important to take the bone marrow biopsy, otherwise you cannot stage the patient. And we know from this that the 5-year overall survival is very poor for mantle cell lymphomas, but with the introduction of rituximab, the overall survival has increased tremendously. Very shortly about eyelid lymphomas. They are rare, but causing many problems for the clinicians. They take a biopsy showing there are really only inflammatory cells. They are using these NF-kappa B pathway again, TCR and JAK-STAT, and they are rare. And for some reason, here we get T cells, and we know if you get a diffuse large B-cell lymphoma of the eyelid, the prognosis is very poor. So this makes sense that we try to differentiate all the ocular and axial lymphomas into subregions, because we know if you have it in the, for example, eyelid, the prognosis is terrible. So again, we try to look at the skin, and again, the eyelid seems to be special compared to the skin and the rest of the ocular and axial region. We try to look, is it worse to have extranodal marginal zone lymphoma in different locations, and at least we know it's not good to have that in the lacrimal sac. So I'm almost finished giving you the 2 last slides. Now people are talking about exosomes, microRNA, communication between cells. And it's funny, it was first developed or discovered in '83, and it was said it was an unwanted cellular component extruding from reticular sites. And now we know they are recognized as natural carriers of many signal molecules. And probably it has something to do as a communicator of drug resistance also in lymphoma. Thank you very much for your attention.